Thank you for being with us today for continuous learning with Bioguard. It is my pleasure to introduce our webinar speaker, Dr. Hongxi Cho. Dr. Cho earned his master's degree in veterinary pathology from National Taiwan University and is a board-certificate veterinary pathologist in Taiwan. He brings extensive expertise in diagnostic pathology, surgical pathology, and laboratory animal pathology. Currently, Dr. Cho serves as a pathology specialist at Bioguard Corporation. In this webinar, Dr. Cho will delve into the fundamental concepts and applied techniques of tumor diagnosis. Topics include tumor biology, the distinction between benign and malignant tumor growth, diagnostic approaches, grading and staging frameworks, and IHC staining workflow. This comprehensive session offers valuable insight and practical tools for precise tumor evaluation in the field of veterinary pathology. Without further ado, please join me in welcoming Dr. Cho.
Well, thank you, Dr. Low. Can you hear my voice?
Yes.
Okay. And now I'm gonna share my PowerPoint. Can you see the PowerPoint?
Yes.
Okay. Okay. Hi, everyone, and thanks for joining today's webinar. I got a bit of cough recently, but I promise it's not contagious from this distance. So thank you for bearing with me. Okay, now let's start today's session, and I will turn off my camera during the presentation. So if you have any questions, please leave your questions in the QA box. The topic we are diving into is pathology insights into neoplasia, classification, grading, and IHC. I'm Cho, a veterinary pathologist, and I'm really glad to have you here. Over the next hour, we'll talk about some key ideas behind how we classify tumors, why grading matters when it comes to understanding how a tumor might behave, and how IHC help us to make better diagnosis. Whether you are in clinical work, diagnostics, or research, I hope today's session gives you some practical takeaways and you can use in your own work. This webinar is held by Bioguard Corporation. Bioguard is a company based in Taiwan, provide accurate diagnostic tests in many diseases. So if you are interested, please follow Bioguard on Facebook or LinkedIn for more information. This report is made by the reporter according to the pathology specialty. The report only contains pathology professional content and can't respond to any questions about other clinical issues or therapy. A little about me. I'm a veterinary pathologist with a focus on surgical pathology, lab animal cases, and diagnostic pathology. I'm excited to share some useful insights today on tumor pathology and IHC. Let's start by going over some basic terms that are key to understanding tumor biology and pathology. First off, the word neoplasm literally means new growth. It refers to a mass of tissue that grows in excessive and uncontrolled way. The term tumor originally mean any kind of swelling, especially caused by inflammation. But these days, we often use tumor and neoplasm to mean the same thing. A tumor is basically an abnormal lump of tissue that grows faster than the surrounding normal tissue. And the key point is it keeps growing even after the original trigger is gone. In clinical settings, we often describe this by size. The mass is usually means something bigger than 2 centimeters, while a nodule is something smaller than that. But regardless of the size, what really defines a tumor isn't just how big it is, it is how it behaves. Tumors grow on their own, without following the normal rules that control healthy cells and tissues. Getting this fundamental idea clear helps set the stage for what's coming next, from how we classify tumors to how we predict their behavior and how we choose the right diagnostic tools. There are some features that neoplasms have, like non-purposive. The neoplasm is not related to physical needs. Independent. The neoplasm is not controlled by normal physiology. Competitive. The neoplasm is competing with normal tissues and cells for nutrients. Parasitic. The neoplastic cells die when tissue necrosis or host death. The neoplasm is mainly composed of parenchyma and stroma. Parenchyma is the main composition of neoplasm, and the stroma are distributed among the neoplastic cells, like connective tissue and blood vessels that provide neoplastic growth structures. Here we can see that is the parenchyma of the tumor, and the pink area is the stroma of the tumor. Here, also we can see the stroma here. Let's take a quick look at where tumors come from, their tissue of origin. The first one is epithelial tumors. These develop from epithelial or mucosal cells, the ones that line the skin, as well as the respiratory, digestive, reproductive, and the urinary tracts. They typically come from the ectoderm or endoderm layers. The second one is mesenchymal tumors. These arise from connective tissues like muscle, bone, fat, blood vessels, or nerves. Their origin is the mesoderm. The third one is mixed tumors. As the name suggests, these contain both epithelial and mesenchymal components. Examples include carcinosarcoma, teratoma, hamartoma. So why does this matter? Knowing the origin of a tumor can help us make a more accurate diagnosis, get a better sense of the prognosis, and even guide treatment decisions. We can see the left one is an epithelial tumor, and the right one is a mesenchymal tumor. You can clearly see difference between the two, like the cellular arrangement in epithelial tumors. We can see they arrange in glandular or tubular patterns, and in mesenchymal tumors, we can see that the cells arrange in streams and pores interlacing patterns. Also, the morphology of cells are different. Now that we've talked about what the tumor is, let's move to how we actually name different types of tumors. In some cases, tumor names are based on two things: the tissue or cell they come from, and a suffix that tell us something about how they behave. Let's start with benign tumors. And the naming rule here is pretty straightforward. It's tissue or cell type plus suffix oma. Here are some common examples for epithelial tumors, which come from surface or lining tissues. Papilloma, a benign tumor of squamous or sensational cell. Cystoma, a benign tumor that forms cyst-like structures. If the tumor comes from glandular epithelium, we call it adenoma, meaning it's from glandular or secretory tissue. Then we have mesenchymal tumors that arise from connective tissue like fat, muscle, or bone. Same naming rule applies like lipoma from fat tissue, fibroma from fibrous connective tissue, chondroma from cartilage. These names don't just tell us where the tumor started, they also imply that it's benign, meaning it's likely to be slow-growing, non-invasive, and non-metastatic. Later on, we'll look at the malignant tumors, where the naming will shift. you will start to see terms like carcinoma, sarcoma, which reflect more aggressive behavior. Now let's look at malignant tumors, which behave very differently from benign ones. Unlike benign tumors, malignant ones invade surrounding tissues and may even spread to distant organs, and the way we name them reflects that. For epithelial tumors, we use suffix carcinoma. The name tells us about the tissue of origin, that the fact that it's malignant. Here are some examples. Adenocarcinoma, a malignant tumor from glandular epithelium. Squamous cell carcinoma from stratified squamous epithelium. Transitional cell carcinoma from transitional cell, like in the urinary bladder. For mesenchymal tumors, the suffix changes to sarcoma. This signal is a malignant tumor rising from connective or structural tissues. Examples include fibrosarcoma from fibrous connective tissue, liposarcoma, which is from fat, osteosarcoma, which is from bone-forming cells. These naming patterns help pathologists and clinicians quickly understand both the cell type and aggressive nature of the tumor, including its ability to invade, destroy, and metastasize. So far, we've looked at the general naming rules, where OMA usually means a benign tumor and carcinoma or sarcoma indicate something malignant. But of course, there are some exceptions. And some of these exceptions are really important to know because they sound benign, but they're actually malignant. There are a few key examples you should definitely remember. Mesothelioma, a malignant tumor of mesothelial lining, usually found in the pleura or peritoneal space. Lymphoma, a malignant cancer of lymphoid tissue, including B cell, T cell, or other cell origins. Melanoma, a highly aggressive cancer of melanocytes, often in the skin or oral cavity. Metastasis tumor, despite the name, this is typically malignant in dogs with a wide range of behaviors. Seminoma, a malignant germ cell tumor, typically found in the testes. Leukemia, a malignant proliferation of blood-forming cells, usually starting in the bone marrow and spreading through the bloodstream. All of these ends in OMA, but don't be fooled, they are not benign at all. That's why it's so important for both pathologists and clinicians to be familiar with these exceptions. Okay, these pictures are exceptions, including here we can see mast tumor and melanoma, and this one is seminoma and mesothelial. Okay, this is a table comparing hyperplasia, benign, malignant tumor. We can see that malignant tumors have characteristics of early differentiation, significant cell polymorphism, abundant mitotic figures, and invasive tumor margins, regarded to poor prognosis. Another key concept in tumor pathology is differentiation. It refers to how closely tumor cells resemble the normal cells they originate from, both in structure and in function. Under normal conditions, stem cell or progenitor cells go through a step-by-step maturation process to become fully specialized tissues. That's what we call differentiation. The normal organized way cells develop and take on specific roles. But in tumors, the process gets disrupted, and based on how much the tumor cells still look and act like their original tissue, we classify them into different levels of differentiation, like well-differentiated tumors and moderate differentiated tumors and poorly differentiated tumors. And well-differentiated tumors usually carry with good prognosis, and poorly differentiated tumors usually carry poor prognosis. Okay, these pictures demonstrate the spectrum of tumor differentiation, comparing tumor cells to their normal counterparts in glandular epithelium. At the top, we see normal healthy cells forming organized glands, serving as the baseline for comparison. And here we can see the well-differentiated tumor. We see well-differentiated tumor cells. They still forming gland-like structures and look very similar to normal cells, which typically correlates with better prognosis. Sorry, my mouse system. Okay, the modern and to the right, we see the moderately differentiated tumors are clearly abnormal. They retain some resemblance to surrounding normal tissue. And to the bottom left, we see clearly differentiated tumor cells. The cells appear disorganized, irregular, and only show a few structural features with normal tissue. And to the bottom right, we see undifferentiated tumor cells, often look nothing like the original tissue. They exhibit neoplasia, meaning they have lost features of normal identity. These tumors are usually more aggressive and harder to treat. Let's take canine mesenchymal tumor as an example. The left picture is low grade and the right picture is high grade. We can see mild anisocytosis and anisokaryosis in the left image, which is a low-grade mesenchymal tumor, and increased cellular polymorphism in high-grade mesenchymal tumor, like we see in the right picture. In addition to assessing differentiation, the pathologist evaluate a range of morphological features that help determine whether a tumor is benign or malignant. These features reflect the degree of cellular abnormality and the genetic instability within the tumor. Here are some of the hall characteristics of malignant tumor cells, like a polymorphism, hyperchromasia, increased NC ratio, and cross-chromatin, and permanent nucleoid. And in abnormal mitotic figures. To really understand what the tumor means for the patient, it's not enough just know what type it is. We also need to look at how it behaves. This image helps us illustrate the key difference between benign and malignant tumors. On the left, we have a benign tumor. They usually grow slowly and were circumscribed, often with a clear fibrous capsule, don't invade surrounding tissues. They just kind of push them aside. And under the microscope, the cells are uniform and they still look a lot like normal tissue they come from. On the right, you can see a malignant tumor, and the picture is very different. There's no fibrous capsule, and the tumor grows in an infiltrative, irregular way. The cells show polymorphism, abnormal nuclei, and it may have the potential to invade and destroy the nearby tissues. And this kind of invasive behavior has real clinical consequences. It affects both the prognosis and the treatment plan. Here we can see the left one picture is a hemangioma, a benign tumor from blood vessels, and we can see the fibrous capsule and is well demarcated. The right one is from a mesenchymal tumor in dog. The tumor is not encapsulated. The neoplastic cells are notated at the margins. One of the most serious things about malignant tumors is that they can spread. This process is called metastasis. Here's a simple breakdown of how it happens step by step. First, the tumor grows and creates new blood vessels to feed itself, and then some cells change and gain ability to break through the basement membrane. These cells then enter nearby blood or lymphatic vessel, and inside vessels, they can stick to platelets or white blood cells, forming some clumps. which we call tumor emboli. These tumor emboli travel through the body. They exit the vessel and settle in new places. Once they arrive, they make new blood vessels again and start growing. Each step involves big changes in how the cell behave. They move more, lose their normal thickness, and break down surrounding tissues. Now that we've gone over how metastasis work, let's talk about two main ways tumor cells spread through the body. The first one is lymphatic metastasis. In this route, tumor cells enter the lymphatic vessel, usually near the primary tumor. They travel through the lymphatic systems, first reaching regional lymph nodes and then possibly spreading further. This type of spread is common in carcinomas like squamous cell carcinoma or adenocarcinoma. The swollen lymph nodes are often the first sign that cancer has started to spread. The second one is hematogenous metastasis. Here, tumor cells invade blood vessels, usually the veins, because their walls are thinner. Once inside the bloodstream, the cells can travel far and form new tumors in other organs. This kind of spread happens more often in sarcomas. The most common target organs are the liver and lungs, since they have a rich blood supply and act like filters for the blood. In both types, tumor cells need to survive the immune system, stick to new tissues, and grow new blood vessels to survive in the new location. That's why metastasis is such a big deal. It's a major factor in how serious the cancer is, and it is also a key target for treatment. Okay. Okay, let's talk about a mechanism of tumor. Our DNA faces constant damage from both external and internal factors. Normally, cells defend themselves using tumor suppressor genes to monitor growth, DNA repair genes to fix damage, process genes to remove damaged cells. And when this system fails due to mutation or defects, damaged DNA may go unrepaired, leading to permanent mutations. Some of these mutations may activate proto-oncogenes, turning them into oncogenes that drive uncontrolled cell growth, laying the foundation for tumor formation. To understand how mutation drive cancer, we focus on two key genes types, proto-oncogenes and tumor suppressor genes. Proto-oncogenes act like the accelerator of CAST. They promote normal cell growth and differentiation. When mutated, they become oncogenes, pushing cells to divide uncontrollably. These mutations are dominant. One allied mutation is enough to cause problems. Tumor suppressor genes are like the brakes of cars. They prevent excessive division, repair DNA, and trigger apoptosis in damaged cells. Mutations are usually recessive, requiring both alleles to be lost before function fails. Cancer develops when this balance is lost, the accelerator is stopped, and the brakes no longer work. Besides proto-oncogenes, the tumor suppressor genes, DNA repair genes are another key defense. Think of them as the cell's repair workshop. DNA damage happens daily from UV light, toxins, or metabolism. In response, cells can pause division and then activate DNA repair genes to fix the damage. But if the repair system fails, either from mutation or damage, faulty DNA may be passed on. If apoptosis doesn't occur, this can lead to tumor formation. Like tumor suppressor genes, DNA repair genes follow a recessive pattern. Both copies must be lost for function to fail. When repair mechanisms are compromised, the risk of mutations and cancer will increase. Let's look at apoptosis-related genes, which act like a cell scrapyard, removing cells that are too damaged to fix. When the cell has severe DNA damage, persistent mutations, or protein misfolding, it triggers apoptosis, a self-destructive program controlled by genes like BCL2 and BAX. If these genes are mutated, for example, BCL2 is overactive or BAX is lost, damaged cells may avoid destruction, continue dividing, and become cancerous. So when apoptosis fails, it removes the last line of defense, allowing abnormal cells to survive and form tumors. Beyond genetics, many external and internal factors can trigger tumor formation, like a genetic predisposition lays the groundwork. Some individuals or breeds inherited mutations that raise cancer risk, but genes alone don't tell the whole story. Environmental factors like tobacco smoke, chemicals, and air pollution cause long-term DNA damage. Radiation can directly damage DNA. Pathogens also play a role, like a papillomavirus is associated with squamous cell carcinoma. FELV and FIV is associated with the benign lymphoma. Diet and hormone matters too. Obesity, high-fat diets, or long-term estrogen exposure increase cancer risk. A unique example is injection site sarcoma in cats, linked to adjuvant vaccines. Chronic inflammation at the injection site may lead to tumor formation. All these factors, inherited or acquired, interacted in a complex way to drive tumor genesis. After the tumor forms, we need to assess its biological behavior, and one key tool for that is tumor grading. Grading looks at how abnormal the tumor cells appear under the microscope to estimate how aggressive the tumor is. The pathologists evaluate cell arrangement, cell shape, and nuclei, mitotic activity, necrosis, invasion, or stromal response. The high-grade tumors show more atypia, more mitosis, and greater disorganization, often linked to poor prognosis and aggressive behavior. Grading helps guide treatment. Low-grade tumors may only need surgery, but high-grade tumors may require chemo or radiation, more aggressive therapy. For example, this is the grading table of dog malignant tumor. The dog malignant tumor could be graded into grade 1, 2, 3 based on the tuber formation, nuclear polymorphism, and mitotic index. The grading is associated with survival time. We can notice that the grade 3 malignant tumor has the shortest survival time, which is this orange line here. And the lymphatic invasion is associated with survival. You can see that the presence of lymphatic invasion has a shorter survival time. Let's take a quick look at grading in canine mesenchymal tumor using both packing and cupel systems. The packing system uses 3 grades, where 1, 2, 3 means well differentiated, intermediate differentiated, and poorly differentiated. And the cupel system simplifies into 2 grades, only low grade and high grade. And the low grade is less aggressive and high grade is more aggressive. And the pupil grading system based on mitotic index, multinucleated cells, nuclear polymorphism, cardiomegaly. And regarding to prognosis, high-grade tumors average survival time is about 3.6 months, and low-grade mesenchymal tumor average survival time is more than 2 years. Here we can see the left one is low-grade mesenchymal tumor, and the right picture is high-grade mesenchymal tumor. the anisocytosis and anisokaryosis are more significant in high-grade mesenchymal tumor, like the right one picture. Let's take a look at public grade kinase tissue sarcomas, which include fibrosarcoma, perivascular wall tumors, nerve sheath tumors, and others. And the grading is based on 3 histologic features, each scored individually. And then we can get differentiation scores. And the index include mitotic score, tumor necrosis score. So then we can get histological grade. Now that we've covered how soft tissue sarcomas are graded, let's talk about what the grades means for clinical outcomes, particularly metastasis and recurrences. Grade 1 tumors, the metastasis is rare, and the recurrence infrequent if margins are close, very rare with complete margins. And then we can see in grade 3 tumors, metastasis is highest risk, and the recurrence likely with close margins, even with complete margins. Recurrence may still occur in the majority of cases. This shows how histologic grade directly influences prognosis. Higher grades means higher risk of spread and recurrence, even after surgery. This is why grading and margin evaluation are both critical for treatment planning. Let's talk about canine melanoma, a tumor that can behave very differently depending on where it shows up. In general, oral melanomas tend to be aggressive, and skin melanomas are usually more indolent or slow growing. But in reality, tumors don't always follow the rules. Some behave unpredictably. So how do we try to predict how a melanoma will act? We usually look at a few key features. And the first one is mitotic index, and the second one is nuclear atypia, and third one is pigmentation. Among these, nuclear atypia often give us good clues about outcomes, but it also varies subjective and takes time to assess. We also have some other tools like Ki-67 index, IHC scoring systems, and even some molecular markers. But here's the challenge. No single test is 100% accurate. For example, you might see a melanoma with low Ki-67 index, but still high mitotic activity or severe nuclear atypia. So with melanoma, the best approach is to look at multiple factors and always interpret them in the context of the clinical cases. These images illustrate prognosis indicators for canine melanomas, both oral and cutaneous, using 3 key parameters: mitotic count, nuclear atypia, and the Ki-67 index. These markers help predict the biological behavior of the tumor and the overall outcome. Take oral melanomas as an example. The mitotic count more than 4 carry poor prognosis. 8% of dogs die within 1 year, and the median survival time is less than 4 months. More than 30% atypical nuclei associated with poor prognosis. More than 19.5 Ki-67 positive nuclei associated with poor prognosis. This table summarizes prognosis indicators for canine cutaneous and oral melanomas based on mitotic count, nuclear atypia, and the Ki-67 index. These criteria help refine prognosis and guide treatment decisions, although no single factor is definitive on its own. Aside from looking at what the tumor looks like. We also need to know how far it has spread. That's where the TMM staging system comes in. It's widely used in both human and veterinary oncology. Here's a quick breakdown, like a T stands for primary tumor, and N stands regional lymph nodes, and N means distant metastasis. Here you can see the table and what means. Let's say you have a case labeled with T2, M1, M0. That means a medium-sized tumor, lymph node involvement on the same side and in confirmed metastatic, but no distant metastasis. This kind of staging helps guide treatment decisions. For example, is surgery long enough, or do we also need chemo, radiation, or systemic therapy? Okay, that's the first part of today's webinar about the tumor pathologies. And the second part is IHC scan. Okay, let's move to this part. One of the most helpful tools we have for diagnosing tumor is IHC. So what is IHC? It's a technique that uses antibodies to detect specific antigens in tissue sections. When the antibody binds to its target, it triggers a color reaction, which let us see exactly where the antigen is and how strongly it's being expressed. IHC is powerful because it gives us qualitative info, locational info, and it's quantitative. In cancer diagnosis, IHC is especially useful to confirm the origin of the tumor cells, help us decide on prognosis and treatment, especially in tricky or metastatic cases. In short, IHC helps us connect what we see under the microscope with what's happening at the molecular level. That's why it's widely used in both human and veterinary pathology today. Now we know what IHC does. Let's go through how it's actually done step by step. The first one is tissue processing. First, the tissue is fixed in 10% neutral ether formalin to preserve its structure. Then the technician trims the sample, embeds it in paraffin, and slices it into very thin sections, usually about 3 to 5 micrometers. The slices are then placed on the glass slides. The second one is the number 2 step is pretreatment. Next, the slides are waxed and rehydrated. Then we perform antigen retrieval, usually with heat or enzymes to unmask the antigens that might be hidden due to fixation. This step helps the antibody bind more effectively. The third step is staining procedure. Now the actual staining begins. First, we block endogenous peroxidase to reduce background noise. Then we apply the primary antibody, which binds to the target antigen. After that, a secondary antibody is added. It's linked to an enzyme like HRP. Finally, we add a substrate like a DAB, which turns warm whenever the antibody has bound. That's our signal. And the fourth step is counterstaining and mounting. To make the tissue easier to read, we add hematoxylin to stain the nuclei to blue. Then the slide is dehydrated and copper sleeved, so it's ready to look at under the microscope. Each of these steps is important for getting a clear, accurate, and reproducible IHC result. One key factor in IHC success is tissue fixation, and most commonly used perspective is 10% neutral buffered formalin. Formalin works by forming covalent bonds between proteins, preserving tissue structure, but this cross-linking can also alter antigen shape, making them harder for antibodies to recognize. To avoid problems like an axial effect, proper fixation conditions are critical. Tissue thickness should be less than 10 millimeters. Fixative volume should be 10 to 100 times tissue volume. Fixation time should be 6 to 72 hours at room temperature. Under fixation, we can lead to tissue decay. Over fixation may hide epitopes and reduce IgG signal. If formalin destroys sensitive antigens, using frozen sections instead to preserve immunoreactivity. So proper fixation isn't just the first step, it's the foundation for reliable IgG results. A critical step in is antigen retrieval, especially after formalin fixation. Formalin creates cross-links between proteins, preserving structures and hiding antigen epitopes. This can block antibody binding and cause false negative result. To solve this, we use heat-induced epitopes retrieval by heating the tissue with a buffer. We break the cross-links and expose the epitopes again. This step is especially important for FFPE tissues, where the antigens are often masked. The buffer pH, temperature, and the duration must be optimized for each antigen. Too little heat won't expose the epitope, and too much may damage it. So antigen retrieval reactivates antibody targets, making successful IgG staining possible. Now let's look closer at heat-induced epitope retrieval here, the most common method for unmasking antigens after fixation. Here, use high heat in the buffer solution to break formalin-induced crosslinks and expose hidden epitopes. Common tools include the microwave pressure cooker, electric rice cooker, and autoclave. Standard settings include 95 degrees Celsius for 15 to 20 minutes, followed by cooling. The buffer pH is also a key. Include citric buffer pH 6 is for general use. Trace EDTA pH 9 is for strong retrieval. EDTA pH 8 is milder for fragile antigens. Choosing the right buffer and conditions often requires parallel testing. Under retrieval will cause weak staining, and over retrieval will cause damaged tissue. Here, HIER here isn't one size fits all. It needs careful control of time, temperature, and pH for better IgG results. Besides heat-based antigen retrieval here, which we just talked about, there's another method called PEER, or PS-induced epitope retrieval. This technique uses enzymes to help unmask antigens that are hidden due to fixation or dense tissue structure. It's especially helpful for membrane antigens. Here is usually a backup option. We use it when here doesn't work. Common enzymes you use include protease, trypsin, and pepsin. The key settings you need to adjust here are enzyme concentrations. And the concentrations typically 0.5% to 0.1%. And then the incubation time around 10 to 15 minutes, and temperature usually 37 degrees Celsius. Be careful of PEER can be a bit tricky. If the tissue is over digested, it might damage the antigen or tissue structure, leading to false negatives. To get clear and reliable IgG results, we need to make sure we control background staining, which is usually caused by things we don't want the antibody to bind to. So what causes background staining? Include poor or delayed fixation. The tissue is too thick, leaking of serum proteins into tissue, use of polyclonal antibodies that may contain impurities or bind non-target proteins. To prevent this, we add a step before applying to the prime antibody. We use normal serum from the same species as the secondary antibody to fill in all the new non-specific binding sites. That way, the primary and secondary antibodies are less likely to stick where they shouldn't. We also block endogenous enzymes depending on the detection systems. If we are using HRP, we block natural peroxidase with hydrogen peroxidase. If using alkaline phosphatase, we block it with levomesyl. If we skip the blocking step, we may end up with messy or misleading staining. But if we do it right, we can get clean, specific, and reproducible results. As we near the end of IHC process, let's talk about how we visualize antibody binding using enzymatic detection systems, often with HRP or DAB. There's three common methods. The first one is indirect method. The primary antibody binds the antigen. A secondary body with HRP is added, and HRP reacts with H2O2 plus DAB, and we can see brown color. That's our signal. It's simple and flexible, but maybe weak or low abundance antigens. The second one is PAP method, peroxidase, anti-peroxidase. We add a third layer, an anti-peroxidase plus HRP complex. The signal is stronger because more enzyme is delivered to the site. It is more sensitive and more complex to perform. And third one is ABC method, avidin biotin complex. We use a biotin labeled secondary antibody plus avidin HRP complex. Each avidin binds multiple biotins will get high signal amplification. Each method has pros and cons depending on sensitivity needs, background risk, and tissue type. Before staining begins, one small but crucial detail is using the coated slides. These slides are treated with substance like poly-L-lysine or silane, which form covalent bonds with tissue proteins and create a hydrophobic surface. During HC, heat, buffers, and multiple washes can cause tissue to fall off regular slides. So coated slides helps the tissue stick firmly, even under tough conditions like antigen retrieval. So while they may seem minor, slide choice plays a big part in HC success. Okay, to wrap up our HC discussion, let's see how all of this comes together in a real practice through the use of HC markers to diagnose different tumor types. This table shows common primary and secondary markers for various tumors. Here are a few key points. We don't rely on just one marker. Diagnosis usually needs a panel of stains. We look at the pattern like a nuclear, cytoplasmic, or membranes, histology, and clinical info together. HC helps us identify tumor origin, distinguish benign or malignant, and sometimes even predict treatment response. So HC isn't just about staining, it's a powerful diagnostic tool that supports better decision in pathology. To wrap up everything, let's go over this diagnostic picture for tumor classification using HC. When morphology isn't clear, we start with broad spectrum markers like cytokeratin for epithelial tumors, dimentin for mesenchymal tumors, CD45, CD18 for leukocytic tumors, and S100 for neuroendocrine tumors. Once we know the general origin, we apply more specific markers. For example, if the cytokeratin and the P63 are both positive, suggests squamous cell carcinoma. This step-by-step flowchart helps reduce confusion, especially in poorly differentiated or metastatic tumors. So instead of guessing, we follow a logical path using HC to guide us through diagnosis based on marker patterns, staining allocation, and clinical info. This image demonstrates that different HC markers exhibit distinct signal localization patterns depending on the nature and function of the target antigen. As shown here, staining may be observed in the cell membrane, cytoplasm, or nucleus, and recognizing these patterns is essential for accurate interpretation in diagnostic pathology. Okay, let's talk about common HC challenge, poor or no staining signals. That's usually happen in antibody dilution multiple is too thin, antibodies cannot recognize target protein, or the titer of antibodies decreased, insufficient dewaxing, or poor tissue preparation, tissue fixation, and tissue maturation, and formalin destroyed protein. And here is some non-specific, here's some factors that will cause non-specific binding, include antibodies from non-covalent bonds with non-specific antigens, and not enough washing, and endogenous enzymes have not been removed, and the antibody is the same species as the detection object. Here we can see that the too strong signal will happen in the antibody. Concentration is too high, or incubation time is too long, substrate acted for too long, and sample dry out. To avoid this, we should titrate antibody properly and optimize incubation and substrate timing, and keep tissue hydrated throughout the process. These three photos are the same views of IGC section with different staining conditions. You can see the different staining intensities. Different antibodies have their own suitable staining conditions, and there's no standard staining protocols. You should try to make a good conditions. Okay, let's see a clinical case that which is spleen lymphoma in a dog. We can see the enlarged spleen in the parenchyma is infiltrated by neoplastic cells, lymphocytes, and the neoplastic cells are positive for CD20 and negative for CD3, which means that it is a B-cell lymphoma. And this is a pollen mass in a cat, and the histological results indicate pyogranulomatous enteritis in the intestine here. And then the IHC for feline infectious peritonitis virus was operated. We can see the positive signals in the lesions. So the final diagnosis is FIP-associated enteritis. Okay, as we wrap up this lecture on tumor pathology and IHC, let's take a moment to highlight the growing value of molecular diagnostics in veterinary medicine. One example is the Bioguard community system, a real-time PCR platform that enables fast and accurate detection of pathogens like feline coronavirus, all in a compact, clinic-friendly format. You can see the right image shows a positive PCR result from a cat clinically. This may suggest active infection or a role in systemic illness, depending on the context. Molecular tools like these help to support diagnosis when signs are unclear, confirm or rule out infectious causes in complex cases, and guide treatment or isolation decisions. When used alongside histopathology and IHC, molecular diagnostics bring us one step closer to precision medicine, offering a clear, more complete picture for better patient care. And Bioguard will be showcasing its latest innovation at upcoming global exhibitions, including Wasaba, London Vet Show, and VMX. So if you plan to attend any of these events, please visit Bioguard's booth and connect with Bioguard. Okay, thank you all for joining today's webinar. I truly appreciated your time and interest in this topic. hope the session has offered you a clear understanding of tumor pathology and the practical application of IC in veterinary medicine. Although we are meeting virtually, I welcome any further questions or thoughts. Please don't hesitate to reach out after the session. Once again, thank you for being here, and I look forward to connecting with you in the future. Stay safe and take care. Thank you.
Dr. Cho, there's some Q&A you can see in the Q&A section.
Okay. Okay. Session. There's a question I see here is the question is there a difference in grading pre-malignant tumors? I don't know what meaning for the pre-malignant tumors. There's no pre-malignant tumors naming like this. We usually use benign tumor and malignant tumor. And the grading system is usually applied in malignant tumor, not for benign tumors. And the second question is, can be concluded that infective metastasis for epithelial tumor, well as hematogenesis metastasis for mesenchymal tumors? This question is, in clinical cases, we usually see this phenomenon, like usually in the epithelial tumors, we see they use a diffractive invasion pathway to get to metastasis, and then in soft tissue sarcoma, we see they usually invade glands to get to metastasis. And the fourth one, I'm sorry, the third one I can not recognize your question. Sorry. So, is there any question?
Okay, thank you, Dr. Cho, for the outstanding lecture. And thank you all for joining us in this webinar. We look forward to welcoming you again in our next webinar. And good night.